Today we will be discussing about the filamentous fungal endophthalmitis. The filamentous fungi are very notorious regarding the resistance they acquire, and also the antifungal drugs have many limitations as they are fungostatic and not fungicidal. So filamentous fungal endophthalmitis, uh, when filamentous fungal endophthalmitis is not responding to either of intravitreal amphotericin B or not responding to intravitreal voriconazole, we can actually combine these two drugs. Though amphotericin B mostly is told not to combine with azoles because azoles will decrease the penetration of amphotericin B, but intravitreal amphotericin B and voriconazole can act simultaneously and may have a synergistic action. Amphotericin B is a larger polyene and goes and it goes and adds on to the surface sterols on the fungi cell wall and forms the pores and increases the permeability of the fungal membranes. Voriconazole is an azole derivative. It decreases the ergosterol in the fungi membranes and hence it is a bioregulator of membrane integrity of the fungus. So this amphotericin VO regimen, that is the amphotericin voriconazole regimen, can be given in previously already IOL explantation plus vitrectomy done patients, and intravitreal voriconazole is given daily as the half-life of intravitreal voriconazole is just 2.5 hours. The intravitreal amphotericin B is given every 48 hours as the half-life. In vitrectomized aphakic eyes of intravitreal amphotericin B is 1.8 days. In the phakic vitrectomized eye of the half-life of amphotericin B is 72 hours and it can be repeated after 3 days. What are the examples of filamentous fungi? Example is Aspergillus and Fusarium. In partial vitrectomized eye, that is the not only the core vitrectomy is done, the peripheral vitreous is not removed. Half dose of amphotericin B every 72 hours can be given. What are the limitations when we are considering this regimen? When the fungal culture becomes positive, the antifungal susceptibility is not done because of the higher cost. There is a development of resistance to the present antifungals in the fungus. The drugs which are available for the fungus are mostly fungistatic and not fungicidal, and there is poor intraocular penetration of the antifungal medicines both systemically and topically. When are the systemic antifungal agents to be used? Systemic antifungal agents are to be used when there is an associated corneal and scleral involvement, when the monitoring of the parameters or the level profile has to be done along with when using systemic antifungal, especially every monthly SGOT PT. The newer azoles, that is the posaconazole or the older voriconazole, can be considered for systemically. This is the actual study, filamentous fungal endophthalmitis, the result of the combination therapy with the intravitreal amphotericin B and voriconazole, done at LV Prasad Eye Institute from various doctors. And this was published in around 2015. And the main thing is endophthalmitis, which is caused by fungi. 60% have to undergo enucleation. 60% have to undergo enucleation. That's why this paper presented the management of 12 consecutive cases of filamentous fungal endophthalmitis. On going through the results, the patients mostly presented to them to the hospital at 22 to 62 hours post-operatively. The fungi hyphae were demonstrated on the microscopy for all of these 12 patients, and 50% of the patients presented with hypopaeon or the AC exudates. Daily intravitreal voriconazole at a dose of 100 microgram per 0.1 ml, and alternate day amphotericin B intravitreally was given at a dose of 5 microgram per 0.1 ml, and this was known as amphotericin B voriconazole regimen, and this was repeated until the resolution of vitreous exudates happened. In their study, 7 eyes had to undergo repeated vitrectomy, and 3 eyes underwent penetrating keratoplasty also. Systemically, antifungal ketoconazole 200 mg twice daily was used in all these cases, especially with the corneoscleral involvement, and the mean duration of treatment in these 12 patients was around 21.5 days, and the range was 13 to 30 days. And patients with corneal or scleral involvement also received topical 5% natamycin and 1% voriconazole eye drops. The culture was proven in 11 out of 12 eyes, and the significant growth of filamentous fungi was seen in the cultures for vitreous samples in 7 out of 12 eyes, and on IOLs on the chocolate agar in 7 out of 12 eyes. The fungal colonies were either cinnamon brown powdery or yellowish green granular, uh, and these were suggestive of either Aspergillus terreus and Aspergillus flavus respectively. And the fusarium, how did the fusarium grow on that microscopy? They appeared as creamy, fluffy, pinkish colonies. So on discussion, main thing is Steenbeck et al. Had hypothesized that azoles may render amphotericin B inactive or be adsorbed onto the fungal cell surface and inhibit the binding of amphotericin B to the fungal cell membrane. But with the study, we found out that this might not be the case, and it might be a synergistic action. Aspergillus terreus isolated from endophthalmitis outbreak in the current series, that is this LV Prasad Eye Institute series, has also been reported to be refractory to amphotericin B in the other in vitro studies. So other thing, this showed that majority 75% of the isolates in these 12 eyes were Aspergillus terreus, which had been previously reported to be inherently resistant to amphotericin B. So main thing is, whenever the fungal endophthalmitis we are suspecting and intravitreal voriconazole does not work, or intravitreal amphotericin B does not work, and there is high suspicion of fungal endophthalmitis, we can consider amphotericin B and voriconazole regimen.